Hello and welcome. My name is Devin Anderson, and I am the engagement coordinator here at the American Association on Health and Disability. I am a white woman with dark blonde hair pulled back into a shoulder-length ponytail, and I'm wearing light blue cat eye glasses and a brown t-shirt. Thank you so much for joining us in this fifth conversation in the Disability and Health webinar series. We're looking forward to diving into a discussion on the social drivers for mental health and the importance of health research that examines these factors, like what is being done with the All of Us research program. Stay tuned for more conversations in our series for the coming year as we continue to explore questions around disability, social determinants of health, and inclusive health research. This event is brought to you by the American Association on Health and Disability as part of our Disability Community Engagement Partner Project, or DCEP. This initiative is working to involve the disability community in health research with the All of Us research program. All of Us is an initiative to engage 1 million or more people in health research to improve individualized healthcare for all. We hope you'll consider signing up to participate in the program, and we will be sharing information about All of Us in the chat throughout this event. Learn more and registration for the program can be found at joinallofus.org/AAHD. Some brief housekeeping before we get started. This webinar is being recorded and will be shared publicly after the event. We have closed captioning and ASL available as well. Please notify us if you have any other access needs or troubleshooting in the chat. We'd like to remind the panelists to speak slowly for the ASL interpreters, and we hope you'll also participate in our evaluation survey, which will appear in the chat and also should have popped up in your web browser. Let us know your thoughts on the series and if there are future topics you'd like us to cover. Before we get started, I'd like to take a few minutes here to let you get to know the panelists before we begin our afternoon together. Aisha Atkins, MPA, CMP, is an award-winning activist, sought-after solutions journalist, and manager of training for Caring Across Generations. She resides on unceded Cherokee Nation territory in Atlanta, Georgia. She is passionate about building an equitable, inclusive, and comprehensive public health and care infrastructure using media, storytelling, culture, and policy change. Her versatility has enabled her to publish works both in academic journals and popular publications, including the American Society on Aging's Generations Journal, Blavity, Thrive, and Nursing Administration Quarterly. And she recently completed the Columbia University's Age Boom Academy 2023 Fellowship Cohort. So welcome, Aisha. Excited to hear more from you. Next, we have Chuck Strand. Chuck Strand is the Executive Director of Rural Minds, which is a nonprofit with the esteemed mission to serve as the informed voice for mental health in rural America and provide mental health information and resources to those living in those areas. Chuck grew up in a small town in northern Michigan near the shores of Lake Superior. His rural roots, combined with extensive nonprofit leadership, patient advocacy, and marketing experience, shape his approach to leading the team at Rural Minds to develop content and deliver programs to confront those unique mental health challenges in rural America, and of course, the stigma that surrounds mental illness. Welcome, Chuck, and I am so eager to hear from you as well today. And last but certainly not least is our good friend Earl Miller. Earl Miller first entered the psychiatric and foster care system when he was 12. He went on to spend as much of his teen years as this is in the system as he did outside of it, which continued into early adulthood and included experiences of homelessness, hospitalizations, and a great deal of trauma. Nowadays, though, Earl is the father of 2 healthy and full of life kids who he credits with helping to tether him to this world. He's also a successful musician and poet who has produced several albums, and he currently serves as the Director of Community Supports at the Wildflower Alliance, and they're doing great work, and I cannot wait to hear more from you as well. So let's get to know the work of the panelists, what they're doing, and what they have to say. And if you do not mind, if each of you could start off with your physical description and then describe briefly how intersectionality impacts the mental health needs of those in the communities that you serve, especially those in the disability community. So Aisha, I'll go to you first.
Good afternoon. Again, my name is Aisha Adkins. My pronouns are she, her. I am an African-American woman with braided hair that's pulled back in a bun and eyeglasses with clear frames. I am wearing a white shirt with black stripes, gold necklace, and gold hoop earrings. And if you could repeat that question just one more time for me, Devin.
Sure. If you can briefly describe how intersectionality impacts the mental health needs of those that you serve, especially those in the disability community, to kind of kick off our conversations today.
Certainly. Well, intersectionality is key. Caring Across Generations really advocates on behalf of family caregivers, disabled individuals, and older adults, making sure they can get access to the home and community-based services that they need in order to live and thrive in their communities and their homes. We understand that one's identity, whether it be racial identity, gender identity, sexual identity, disability, etc., really informs the way that we all experience care. And having access to culturally relevant and culturally sensitive care, having access to care within the community, outside of institutions, in a trusted space, in shared space with others who appreciate this shared sense of culture and shared definitions of culture, is key to ensuring that the access to the care is received, and that the individuals are receiving the care that is most relevant and most effective for them.
Great, thank you so much. I love that. Chuck, how about you? Same thing, brief introduction, and tell us more about intersectionality with those that you serve.
Happy to. Hi, my name is Chuck Strand. I'm Executive Director of Rural Minds, and want to thank you, Devin, for the opportunity to be here, and my co-presenters. I am a white male with brown graying hair, not as much as I used to have, and I am wearing don't have glasses, and I am wearing a small checked blue and white shirt buttoned down with a collar. And Rural Minds is the the only 501c3 national nonprofit that is focused specifically on rural mental health and providing free resources information. And interesting about this intersectionality, recognizing, of course, that every person has their unique circumstances that are their story, so to speak. But I think that a lot of times the general population kind of looks at rural America in somewhat of a homogenous, through a homogenous lens, and within the rural communities, of course, really is there's some consistent threads that go through it. The most obvious and apparent, unfortunately, is mental health inequity. But each of the organizations or the communities is really unique, and I think that in all fairness to the people who live in rural America, any marginalized segment of the population that you would find in any part of the country, large cities, those folks are still in rural America. They're just more isolated. And there are many unique challenges we'll get into a little bit more in the presentation as far as some of the challenges and barriers that are unique to rural America, but that definitely feeds into the experience that someone in rural America has to go through in order to recognize a potential mental health issue, get a diagnosis, and then get treatment.
Yes, thank you so much. I think I think a lot of people can understand that commonality, the common need, the mental health is definitely doesn't matter where you live, where you're from, what your background is, that is a common thread across a lot of communities. So thank you, Chuck, so much for that. And then Earl, how about you? Let's get a brief description and a little introduction. And again, intersectionality with the wildflower community.
Hi, I'm Earl. I am a African-American man with short brown hair, short brown beard. I'm wearing a black Nike hoodie. I'm not as fancy as the rest of my friends. And I have black glasses. And I'm wearing a black headset. And probably somewhat noteworthy, I am sitting in front of a coffee shop in Washington, D.C. So you may see city sites behind me. So Wildflower Alliance is a peer-led agency in Western Massachusetts. We overlap with a large urban community and a large rural community. I will say that we are a bit part of being led by peers is that I think we have a bit more, not than anyone else, but our lens is often very practical, but also a little philosophical. The history of mental health in this country is intrinsically tied to chattel slavery and its legacy. One of the first American diagnoses was drapetomania, which was the psychosis of escaping slavery. And what we find is that folks often live in places where the more community-based mental health services aren't there, but the more carceral ones are there in abundance. That folks, in order to get help, are forced to leave their natural support network for large periods of time. And then they're returning, sometimes those networks are not there for them when they come home. People of color are less likely to live in places with mental health, with functioning mental health communities, but they are twice as likely to be diagnosed with things like schizophrenia. And I would point out that the largest mental health provider in this country is the Cook County Jail in Illinois, that largely Black men are experiencing mental health through the lens of carceral systems. We see folks experiencing homelessness, and this little bit of the chicken or the egg thing. Was the mental health the thing that made you homeless, or was the experience of living in a country where lots of people have more than they need and you can't make your basic needs? Is that in and of itself, is that experience in and of itself a trauma that significantly alters your ability to move through the day? And I would say our most important question, I think this is the philosophical piece, is we sometimes wonder if people are limited in their access to things because of their disability, or they're disabled because of the lack of access in spaces. And so what we often think about is the way in which when folks with disabilities or challenges, or however they identify them, have a problem, it is often seen as very personal, even though the solution is systemic and large. I worked for a state mental health agency for a period, and we were talking about accessibility for trans folks and single bathrooms that were non-gendered. And one day someone said, wait, don't we all want single stalled bathrooms? Like, isn't this a universal good? And the ways in which that accessibility is generally beneficial for everyone in some space. So yeah, I think that's it.
No, that was great. Thank you so much, Earl. I really appreciate all of your perspectives on your communities, and I look forward to hearing more from all of you here. Just a quick reminder before we get into our panelists and their presentations, if you have questions for the panelists, please put the questions in the Q&A box. We're going to try to leave the chat open for any accessibility issues that anybody may have. So feel free to put any questions you have in the Q&A. We will be getting to them here at the end, but I would like to give Aisha Atkins our full attention right now. So go ahead, Aisha, you can start.
Thank you very much, Devin. Sharing my screen now. All right. So I'd like to discuss community care, mental health, and caregiving. Of course, just a brief disclaimer that I am not a mental health practitioner. I am simply a family caregiver and an advocate who is passionate about creating equitable care infrastructure, as Devin mentioned in my introduction. I'd like to share a little bit more about myself and my lived experience, the national mental health and care crises, the impact on this country, home and community-based services, and community care. So again, as Devin mentioned, I am the training manager at Caring Across Generations, which is a policy advocacy organization advocating on behalf of family caregivers, disabled people, and older adults. I was also the family caregiver to my mother, Rosetta, for 10 years, who lived with frontotemporal degeneration, or FTD, and current family caregiver to my father, Ron, who is a 4-time stroke survivor and prostate cancer survivor living with type 2 diabetes, chronic kidney disease, and vascular dementia.
1 second, Aisha, real quick. People are
Yeah.
saying they cannot see. Can you make the slides larger? They cannot see your presentation.
Oh, that's odd. Okay, let's see here. Give me
Sorry
just
about
1
that.
second. No, that's certainly okay. We want to make sure this is accessible to
For sure.
everyone.
Thanks.
View full screen. And let's see, is that a bit more accessible for folks
It didn't shift.
rather than being in presentation mode? Let's see here. I'm just looking in the chat.
It looks like it's sharing your desktop view and not necessarily the slide.
Okay, that's interesting. All right, let's see. Bear with me just briefly, folks. Okay, because I am not seeing what you are seeing. Can you share? Okay, hopefully that has addressed any visibility issues.
This looks great. Thank you so much.
Fantastic. Thank you for letting me know.
No problem.
Additionally, I am a speaker, a writer, as well as a dementia and mental health advocate. So we are, encountering a national crisis that we've been in for, if we're realistic about it, centuries, but it's being more noted today. States that are seeing the most cases of untreated mental illness in the hundreds of thousands include Hawaii, Arizona, California, Alabama, and Texas, where care is inaccessible. Additionally, when we're looking at family caregiving, we're looking at 60 million Americans who provide unpaid care for a family member with a mental or physical disability. Of course, we know that all ages can be impacted by mental health challenges, but what studies have lately found are that baby boomers are increasingly anxious, or reporting being, the reports of being anxious have gone up. And also Gen Z is in dire need of assistance with mental health and is more likely than other generations to report mental health concerns. Institutions may not be the answer, but as Earl mentioned, many people experience mental health through carceral systems. We know that older adults who may be facing mental illness, cognitive decline, are often faced with the decision, or their family caregivers are faced with the decision as to whether or not they should be institutionalized in a nursing home or other long-term care facility. But we know that 77% of adults over the age of 50 want to age in their homes as opposed to in an institution. Alternative options may limit the use of institutions, I should say the overuse of institutions in this country. Those alternatives may include options such as community health workers, mental health doulas, certified peers, and wellness coaches. Additional options include dementia-friendly cities, which allow people to live within the community rather than in isolation or in unfamiliar surroundings that may negatively impact their mental health and well-being. So what is community care? Community care enables individuals to find belonging, connection, and collective support in a welcoming environment. Factors which are tied to improved recovery from mental health conditions and overall well-being. Additionally, community care allows for individuals to feel valued and taken care of in a mutually respectful manner by members of their community. This is incredibly important to note because when we think about community care, oftentimes the community reflects one's individual identity and lived experience. This is valuable and absolutely invaluable to impacting one's mental wellness, feeling that you are being understood on the very base level of who you are and the reflection of your life. That can make a tremendous difference in terms of how care is given and received. So you heard me mention home and community-based services, or HCBS, but what are they? While they are types of person-centered care delivered in the home and community, a variety of health and human services can be provided in order to provide assistance to those with functional limitations. Now, primarily, currently, HCBS is focused on individuals with physical disabilities, which is obviously a limitation of the program. This is a governmental program that is funded at the federal level through Medicaid for those who are using Medicaid waivers. People may choose to pay out of pocket to access these services, but it can oftentimes be very cost prohibitive, particularly for historically marginalized communities that do not have access to things like generational wealth. Some of the benefits of HCBS are that it can be cost effective as opposed to institutionalization, which is often very expensive from more of the governmental standpoint and how much money is going into these institutions. It can be culturally responsive, removing things like language barriers, including things like one's faith practice, for example, familiarity, accessibility, bereavement services, and again, waivers that can really help to mitigate the costs of providing care for a family or community member. Some of the challenges, of course, with home and community-based services include things like limited access to providers, limited availability of qualified caregivers, paid care worker burnout, lack of 24/7 medical professionals, some cultural biases in medical professionals, in the assessment processes, no skilled nursing care, a lack of access for tribal communities, and a lack of funding. And again, it does not currently include enough support for those living with mental health challenges. So I would just like to close by saying that community care is mental wellness. Having access to care within your community truly does exponentially increase your likelihood of being able to live well and with dignity in your home and community in comparison to institutionalization that can often be used in a punitive sense, as was mentioned earlier, and is not always accessible and does not always take things such as cultural relevancy into consideration. Thank you. Let's see.
Thank you so much, Aisha. So much good information. We here at AAHD are taking a fine look right now at HCBS. So this conversation is really timely. So thank you for that. I'm looking forward to continuing the conversation with some Q&A in the chat afterward. Next up, we're going to hear from Chuck Strand with Rural Minds. Take it away, Chuck.
Okay, thank you. Let me share my screen. Okay, again, thank you for the opportunity to be here. We just wanted to talk a little bit about recognizing the unique state of mental health and equity in rural America and the work that we're doing through Rural Minds. So the organization Rural Minds was really founded by Jeff Winton, who was a lifelong dairy farmer, and it was the tragic inspiration was the death of his 28-year-old nephew Brooks, who was the father of 3-year-old twins. And when that happened, a lot of people in Jeff's community, farming community, told Jeff and his family to not speak about the cause of the death of how Brooks died, and just say he died of natural causes. And Jeff and his mother, who's since passed, made the very courageous decision to talk openly about the suicide of Brooks. And by doing that, they opened up the conversation to other people in the community to know that it's okay to talk about mental illness. And we all know that not only is it okay to talk about mental illness, but it's the only way that things can get better. It needs to be verbalized, but we're really fighting the additional stigma in rural communities that goes along with mental health challenges. We're talking about a mental health emergency, and we're not trying to be dramatic, but it's just based on the facts that the latest research from the CDC states that people in rural communities are 64 to 68% more likely to die by suicide than people in major urban areas, which is really shocking. The stat before that was 25% more likely, which was high enough, but this is just truly a crisis. And farmers and ranchers, as far as occupations, are more than twice as likely to die by suicide than other occupations. Youth are having a hard time across the board, in regardless of where youth are living, but those who are in rural communities are at a greater risk of suicide, again, when compared to large urban areas. And just the overall depression and anxiety of youth is just more prevalent among the rural population and youth, and out of the 46 million folks who are in rural America. So our mission at Rural Minds is to serve as the informed voice for mental health in rural communities and to provide mental health information and resources. We recognize that's a heavy lift, and we certainly can't do that without partnering closely with a lot of organizations who are in rural America and have a ear to the ground. Our vision is a rural America where there's no more silent suffering or stigma that's surrounding mental illness. Some of the barriers that are inherent in rural communities include just the overall lack of healthcare providers, whether it's a general practitioner or any specialist specific to mental health care. And these are just a few of the stats that drive that point home. In addition to the barriers that are inherent in the healthcare system, there's a lot of things that go with just living in a rural area, whether it's a farm or ranch or just a small town or isolated area that's kind of off on its own. But people who are in a rural area tend to value the attribute of being independent and being self-reliant, self-resilient. And a lot of that is just due to the fact that you have to be. I mean, when you're in the suburb or a city, you can, call somebody to swing by and fix your broken pipe, and they'll be there within a day. But in a lot of rural communities, you just have to figure it out and do it yourself. And there's also the lack of trust in a small community. The good thing, bad thing is that everyone knows you, but that can be an issue as far as keeping anything confidential. And with that stigma that surrounds mental illness, that can be an issue. People don't want to, many times, the source of the stigma is that people don't want others to judge them as being incompetent or less capable, whether that's as a parent, a spouse, an employee, whatever it might be. And then, you know, we all know there's challenges with getting an appointment with a mental health provider, but that can be even more difficult with the lack of mental health professionals in urban areas. And when you do get an appointment, at the time that you're away from the community, you know, a lot of times people don't have the transportation, so they have to rely on somebody else. But regardless, it kind of speaks back to the lack of confidentiality when you're gone from your job or gone from the family for a day or whatever it takes to get there and back from an appointment. People want to know where you were and what you were doing. The internet is making progress as far as accessibility throughout rural communities, but it's not there yet, of course. And there's just, it's non-existent in a lot of areas. So the option of a telemental health appointment really isn't an option. And what we're doing right now, having this webinar, is not an option for a lot of people who don't have internet, or a lot of people in rural communities, and many don't have internet. And the fact is that many people in rural communities are less likely to have health insurance. And even if there is health insurance, the coverage for mental health care is a huge question mark. Without somebody to talk to in their community, without, you know, fearing a lack of confidentiality, a lot of people think that there's no one that they can speak out to in terms of connect with outside of their community, and that causes them to feel more isolated. The the good news is that, you know, now there's 988, which is that 3-digit calling code that's been around for almost 2 years now, which connects folks with free confidential services for talking with a mental health professional that can answer questions. But that's, you know, it's a really good resource, but it really doesn't take the place of something that's specific to rural communities. And a source of the stress really is that weakening economy. It's very, you know, prone to fluctuations in the weather and the market, and the financial stress can be huge as far as anxiety and depression. And back to the point I made earlier, as far as the solitary, you know, barriers, any segment of the population, whether it's, you know, any disability or race, class, sexual orientation, gender identity, all those folks are still in rural communities, except they're just more isolated and they feel more alone many times. So what we've done is we've looked at, you know, what can we do to make a difference, and to help people move forward in rural communities specifically. And we are big on partnerships, and one of our biggest and most developed partnership is with the National Grange. They're a very old nonprofit in rural communities. They were founded in the 1800s. They do a lot of work in legislative advocacy in DC for rural communities, but we're also partnering with them because they have 1,400 locations around the country, not in every state, but with that, they have boots on the ground. So again, back to our mission of being the informed voice, the Grange is one important partner for informing us of what are the unmet needs or underserved areas. And that's what we worked on as far as developing this new program that we launched with the National Grange. It's the Mental Health Resilience Program. And it just really speaks to the fact that people in rural communities often, as we mentioned before, are independent, they're self-reliant, and they're self-resilient, and they recover quickly, they're tough, and they want to do things themselves. So we want to meet people where they're at. And even though that independence and self-resilience can be a barrier potentially in getting the help that people need, we developed this program that provides a lot of resources to look at that self-reliance as a strength. We're meeting people where they're at. So if people want to do it themselves, and we've created this webpage that allows people to access free information, pull it down, print out PDFs or whatever it might be to do it themselves. And what I'd like to do is just, let's see, share my screen to just take a quick look at our website here. So this is the Rural Minds website, and we've got a link here to this webpage that we're talking about. But even if, you know, this is not there as a banner in the future, you can still go to Rural Mental Health Resilience Program. I'm going to just do a quick tour of this because I think it's really important that people know how to access this information. So again, we're talking with some of the stats here as far as what is the reason why we're referring to this as an emergency, but we don't want to leave it at that. We want to give people the information and resources that they can be part of the solution. So what can they do to make a difference? And we've got the table of contents here on the right that's broken down by topic, and all of these are direct links to the content that's shown below. And so I'll just, oh, I want to show you this too. So we want to make this a back and forth, a dialogue. So if you're on the website, you find something that you don't like or you do like, but mostly if you don't like it, this is an anonymous opportunity here to share your comments with us and submit that. Or if you want to have a conversation or share something openly, you could just send an email to info@realminds.org. A lot of these facts about mental health, you click on there and you just go right to a PDF, and you can print this out if you'd like. But this gives a real good, nice snapshot of the program. What's it all about? Why should people care? What can you do about it? And this is something that if any of you are watching and are interested in being part of this movement to raise awareness for rural mental health, this is something easy to do. Just print this flyer out and put it on a bulletin board in a local cafe or place of worship or local business, whatever it might be. And it tells people, how to get started. You can either click on the QR code or go to the URL and get access to this program and all the materials that we're talking about. A lot on stigma too, as far as even some of the myths that go with, what people think about stigma, like even and suicide too, like talking about suicide will make it more likely to happen. So, I mean, that's not true, but there's many things that are just really important to recognize as facts. And the suicide awareness and prevention is important too. So there's some of the signs of suicide, how to talk to somebody about suicide. It also links to this other webpage that we did previously last year, and it's all about awareness and prevention. And it includes a link to a webinar we did with the Suicide Awareness and Prevention Training. Talk Saves Lives. So if anyone's interested in that, please log on and check that out. It's recorded content, but there's a lot of great information here specific to suicide awareness and prevention. It goes on quite extensively. We hear a lot about bipolar, schizophrenia, general anxiety disorder, schizophrenia. What are these things? And so this is really the point of the fact sheet. So they're all formatted similarly, but it's set up so it's a quick read. It's one page, double-sided, and again, these can all be printed out if you're interested. But like, what is the mental health condition? What are the symptoms? How do you diagnose it? How common is it? And then what do you do to manage it? And just real quick information. You can of course drill down into more details with the links that are on these too. So I mean, there's a lot of information. The only thing I quickly want to do before we wrap up is recognize that there's these other programs that if somebody wants to do something that's more of has a bigger impact on the community, we have these PowerPoint presentation similar to what I'm doing right now. We have key messages for like a TED Talk community conversation. We recognize that not everybody is comfortable doing that type of thing, but for those folks that want to step up and participate in that capacity, we encourage people to do that and have provided the information for people to do that. Let's see what we've got. So yeah, the recapping, you can log on to the webpage, print out the facts or flyers, share the URL and the key messages in the slides. And just wanted to mention that it's so important that we speak out, because some of the people that really are in the most desperate situations, they can't speak for themselves a lot of times. So it's important for us all to rally around doing what we can to raise awareness for rural mental health and the unique challenges that are surrounding folks who are struggling in rural communities. So thanks so much for the opportunity. I appreciate it.
Thank you so much, Chuck. I already see some questions coming in. I'm definitely looking forward to diving in more with this. I think what you shared is so important for so many of us, and I know for a lot of us, it definitely touches home a little bit in the community concerns. Next up, we're going to talk to Earl and hear more about Wildflower Alliance, what they're doing. And I don't know why I can never say that correctly, but I promise I'm working on it.
Yeah.
Thanks.
So we used to be the Western Mass Recovery Learning Community, which recovery learning communities are a statewide contract, and we had the Western Mass one. And in 2020, we went through a rebranding, recognizing that so much of that language felt thrust upon us. And kind of wildflowers grow anywhere, and so I think it's a pretty simple way of saying that. So the Wildflower Alliance. See, I'm going to go back to the old one too. Wildflower Alliance. We have really 3 core tenets. We do training, advocacy, and peer support. Our training starts with, we train folks on modalities to be helpful with folks. One of those being the Hearing Voices groups. The Hearing Voices Network comes out of the UK. And it started with actually voice hearers feeling really isolated. And so you can find the story online, but it basically boils down to a psychiatrist brought a voice hearer onto a radio show and polled the audience that night on how many folks had experienced voice hearing in their lives. And it was about 10% of the folks, which is about as common as being left-handed. And just that understanding that you weren't alone was transformative for some folks. And then these folks decided that they were going to come meet with each other. And that has continued on. I think that was in the 80s till today. So Hearing Voices groups happen all around the country in a variety of settings. Ideally, they are led and facilitated by someone who has the experience of voice hearing. In our community, they are always facilitated by someone in that regard. Alternatives to Suicide is a group we started. And so suicide is kind of the taboo in this world. Sorry, I'm going to try to block the wind. It is the taboo in this world of, if you talk about it, people might be more inclined to act upon it. There is no data that says that. And what we often find is that folks are traumatized by the response to those feelings as opposed to the actual feelings. And so alternatives to suicide groups are a safe place for people to talk about that feeling. And without judgment, without fear that they're going to be removed from their community, or that likely the police are going to be called. And we train organizations around the world on that approach. In fact, one of my counterparts was in Australia not so long ago. She is in Finland today. And so this is an approach we started in Western Mass, but that's really expanded. We also do trainings on things like anti-oppression. We train providers, and we really try to create spaces for folks to think about what it's like to experience these things. I think it is easy to think that just because a person has been removed from your immediate purview, that they've been solved somehow. But often when people first talk about their mental health experiences with folks, their emotional distress, they are thrust into a hospital, which is a fairly austere place with people you don't know, and you are kind of only gonna leave there if you comply. So the support is its own trauma. And often it takes people unpacking that to unpack the larger trauma underneath it. So we train folks in the context of that. We also provide consultations to agencies, to individuals, and to families sometimes with particular challenges they might be experiencing. Advocacy is kind of why I'm here in Washington, D.C. today. We are really trying to help legislators think about the policies that might allow people to take control of their experiences, but also to help shape the system into something that's helpful. I often in these situations hear people talk about, we need more hospitals. So actually our movement, like a lot of social movements in this country, it took a Supreme Court case for us to arrive at where we are. It was the Olmstead case. In Massachusetts, we actually have the Olmstead Act, which was a response to that. And it is the idea that folks with a disability, with a mental health diagnosis, have a right to treatment in their community. And folks may say, well, what if the treatment is somewhere else? Well, the Supreme Court has decided that removing people to get treatment is a form of segregation, which is constitutionally illegal. So that is why you are not able to get some resources in the hospital, because people have a right to live where they choose to. And just because you have a mental health diagnosis, even a potentially scary one, doesn't mean that you should be segmented off from folks for the rest of your life. And we know that that was the experience of people in this country for a very long time. Here, we're talking about peer respites, and I'll get more to that in our peer support piece, but advocating for the country, for the federal government to expand their support of that, and to do that through legislation that allows some equity in those things. I think to my predecessor in this today, the idea that you have to live in an inner city to access the full range of resources is really a failure, because we do know that a lot of people live very far away from the kind of places that have the full range of resources for them. And then peer support, which is really my kind of bailiwick here. We work with people. We have community centers in Massachusetts. We have them in Springfield, Holyoke, Massachusetts, Greenfield, and Pittsfield. They are places for folks to come during the day, and access folks who, I'm gonna wait for the bus to pass, and access people who maybe have had similar experiences to them. Our Springfield Center is our largest. It's also the one that I work most often out of. We see 80 to 120 people every day. Largely, those folks are unhoused, but we also will have people who are fresh out of jail. We've started to have folks who are migrants who are being bussed up to us. And our motto often is we will do anything with someone. We don't do much for someone. We want to teach people how to kind of solve their own challenges in ways that if we go away someday, they still have the ability to navigate them. We have a peer-run respite. It's called the FIA. It is the first one in the state of Massachusetts. It is a house. It's an alternative to the hospital, but sometimes folks go there when they weren't even thinking about the hospital. You get to have your own room. The only locks in the building are the ones that people get to put on their own doors. People get to make of that experience what they may. They aren't forced to be there. I actually went to a FIA myself during a pretty hard breakup. And I was still able to go to work. I was still able to be a parent to my children. And I was able to get access to meaningful supports from people who were thoughtful about the way they helped me to navigate that. And we were really proud that we were in the kind of final stages of opening a new peer respite up. And it will be the first in the world peer respite for LGBTQ folks. So we're hoping to do that in Holyoke, Massachusetts. And the idea is that for those folks, there's a particular sort of trauma that often is pathologized as mental health, but may not be they may be experiencing more of the kind of societal pressures around identifying with your own sense of self. We really think about people as the experts on their own experience. Sarah David, our director, when I was very earlier in my career, said something that was transformative for me, which is that everyone's life makes sense in the context of their experiences. Often, let that bus pass. Often when we meet folks who seem like they are experiencing kind of life interrupting challenges, you realize that the way the system is built right now is where you get the most resources is when you are in the most crisis. When the most people are supporting you is when you are saying scary things and experiencing really hard things. But as you recover and as things move forward, you lose those. Every step towards kind of the life that you choose to live, you lose people who maybe were important to you. And so in our community, we don't work that way. We work through challenges with people, but on a good day or a bad day, we're going to show up for you. You can be with us and we're not going to judge you based on your worst day. We operate really on a value set. The idea being that, you know, we don't want to make this never ending list of rules of conduct, that situations are contextual. I will give a good example. We are currently supporting a veteran in our community who's been homeless for about 12 years, and he lives in the woods and has adopted a bobcat. And you might think that's wild. I do too. But his bobcat is meaningful to him. And so we were able to work with him to find some accessible housing, but he's worried about his bobcat. And so I never thought in my career that I would be thinking about where can you get someone to take in a bobcat. It turns out there are rescues that take in bobcats. It took a lot of searching on our end, but in a rural community near us, there is a feline rescue that has agreed to take this bobcat. The bobcat can't live in the wild because it is his bobcat. Bobcats aren't supposed to be somebody's pet, but it is. And so this sort of problem that in a system might have been seen as delusion, right? If he had gone to a provider and said, I have a pet bobcat, they probably wouldn't have believed him. I have seen pictures and I've seen the bobcat. It is both are true. Or it might have been seen as some sign of aggression or disorder. What we really understand is that this person who is, for really valid reasons, a man who has seen war, has found a bond with this animal. And I have a dog, which is maybe a more socially acceptable pet, but that's meaningful to me. And as opposed to trying to fix him and change his approach, we took him as he was, we met him where he was, and we found a solution that will allow him to move into an apartment and find meaning in his life in a way that makes sense for him. And at no point in there did we have to diagnose him or kind of stop to figure out what was wrong with him. We were able to really think about what was right with him, that this person who's really struggled was able to kind of build this capacity to love him. And I think that will serve him well as he moves forward. We do things like that all the time. We also have a peer bridging program. So some of our folks go into local hospitals and work with people and advocate with them for what they need. We work in a continuing care hospital, which is essentially a state-run unit that is run privately out of a consent decree. And we have peer specialists who go in there and support people around what they need, and also to advocate for them to have a voice in what their life is going to look like when they leave that unit. As someone who has spent a long period of time in a hospital before, you think when you get out that it's going to be easier, but you missed all that time you were in there, and someone has to tell you how to move through the world, and sometimes we can serve that role for folks. The other question I sometimes get at these things is how many clients do we have? And the answer is 0. We're a community, so everyone who works with us is a community member. I started out as purely a community member. I volunteered for 7 months, and as I was able to increase my capacity to support people, the community found opportunities for me to join employment. But my responsibility and my responsibility to our values never changed. It was the same the first day I walked in as it is today, as a director. And yeah, so I would say this thing changed my life. I only started showing up here because I couldn't get a job at a Dunkin' Donuts. I thought that was the best I could do. And lots of people in my life had told me that the best I could do was a state hospital stint. And if I was really, really accepting of that, maybe a group home. And as much as I think compliance is seen as the way, if I had taken them at their word, I wouldn't have had my kids. I wouldn't have experienced all the really good things I've had, and I wouldn't have experienced some of the really hard things that shaped who I was and forced me to think critically of who I am. We are a community that isn't afraid to be wrong, that apologizes to people. We mediate disputes with people. We recognize that we are not perfect, and that sometimes our approach is not the correct one. I believe we're a community of humility, and when we talk about mental illness, and that's language that we don't use as a community, sometimes, like, what's next? If you're told that your brain is broken and that's largely it, well, then what do you do with the rest of your life? What do you do with the rest of your life if your options are so limited? And I would encourage folks, if you're thinking about working with people, you're thinking about doing research, that you allow space for folks to surprise you. Some of the most bright folks I've ever met are folks who, when I first met them, they were in pretty dire circumstances, but the human spirit is pretty strong. People are incredibly resilient. And sometimes if you work it right, you can channel people's frustrations with their care into really magical moments. I have really magical moments all the time. And that may have been too ethereal for you all. I hope it wasn't. I know that, like, in research, it's largely about data. We don't think about folks like that. We think that sometimes the individual story is more powerful than the data. And you may disagree with us or agree with us, but I think we all have something to learn from each other. So I'm excited to learn alongside you all.
Thank you so much, Earl. I have so much I personally want to talk about with you. Super interested in learning more about how one can become friends with a bobcat, just in case there's, for a friend, for a friend. Before we get into the Q&A though, I want to take a few moments here again to thank the panelists again for their time. We really appreciate all your expertise and kind of pivot for a moment here and talk about the All of Us Research Program and how what we're doing with the All of Us Research Program connects directly with the conversation today. So the All of Us Research Program, as we kind of briefly mentioned, is an initiative from the National Institutes of Health to create the country's largest and most diverse health research database with the goal of enrolling 1 million people or more. And I'm so happy to be able to announce that as of May 29th, more than 800,000 people have joined the program. So we're almost there, and don't think we're going to stop at 1 million because we're just going to keep going. More than 80% of all of the participants are from groups that have been the majority underrepresented in health research in the past. And that is the ultimate goal of the program, is to ensure those that are historically underrepresented, racial minorities, sexual and gender minorities, the rural community, disabled individuals, are then being included in the health research. In the writing community, we say a lot of times, write the book you want to read. And so in health research, it translates into, be the faces you want to see in the research. And that's why it's so important that we bring those faces into the fold. And when it comes to the social drivers of mental health, All of Us really creates that opportunity to study the social drivers of mental health in some key ways. First off, the program uses health surveys to collect data on social factors that impact health, including, like we talked about with the panelists, where you live, how socially connected you are, how socially connected you feel. That also is important as well, and your ability to access healthcare. These factors and others impact your mental health, including all the intersectionality pieces as well. You can learn more about the mental health research that is currently underway with the All of Us Research Program at researchallofus.org /discover. And the organizations that are with us today also are interested, obviously, as we've heard, in improving holistic mental health care and well-being for all. And they're all doing their part in their own communities and making it really accessible for the communities. And not only accessible, I think it's important to mention that it's all doable for you in your communities as well. Chuck, Rural Minds literally gave y'all the toolkit. He said, here's the website, here's the printout. So everything can be done in a way that's duplicable. So I'd like to turn over to the Q&A now. Just so that in the interest of time, so we can stay on track. So if any of my cohorts would like to read off some of the questions. Oh, Cassandra, hello.
Hi, Devin. Thank you, Devin. We hope everyone's enjoying the webinar so far. I'll start off with the first question that we received, or I guess it could be a comment too. So this is from Harry. I believe this is when Chuck was speaking. There's almost always a huge gap between where the government takes away support and where people don't need that support anymore. So I believe that's just a statement and a comment based on that. Moving forward, I will go ahead and to our Q&A box. Again, Harry has a question, and I believe this is for Chuck as well. I've heard a bunch lately that suicide is much more likely for gun owners. I wonder at the correlation with rural residents owning more guns than the urban areas. So then, is it worth reaching out to the NRA or other gun-related organizations to work on the machismo culture, destigmatizing, asking for help because their members' lives are literally at stake?
That's a really good comment and a good question. And the research shows that the majority of deaths by suicide are by firearms. And also we know that the accessibility of a lethal means for death, whether it's firearms or any other means of suicide, is really a fleeting thought or priority, and anywhere from like 10 minutes to 3 hours. If the person that's in a really dark place at the moment, if they can be secluded from any lethal means, they most likely will reconsider what they were attempting to do. But back to the specific question about firearms, we haven't worked directly with the NRA. We've done some presentations that were through NRA members, and we recognize that we need to be respectful of gun owners, but we recognize also that we just said that, much of the deaths by suicide are from firearms. So the message that we really try to lead with is the fact that, be a responsible gun owner. I mean, guns aren't only in rural communities, but whenever somebody owns a gun, be sure that it's safely stored. It's not easily accessible, except for the right reasons, as far as you want to make sure that people that are in a dark place or who are suffering from a mental health condition that may make them more prone to being volatile for suicidality, they should the gun should not be accessible for them. And for people that are very much pro guns, it's just a matter of knowing that the fact is people that die primarily by firearms. If someone chooses to have a firearm, then be responsible with it and be sure that it is in safe storage and it's not accessible for the people that might harm themselves.
Thank you,
I
John.
would just add on that there's a wealth of harm reduction things that folks can do if they choose to own guns. Putting multiple steps in between you accessing it, putting it behind locks. Really, when we talk about suicide prevention, largely we're talking about a time thing. The more time that folks have to think it through, the more likely they are to decide not to. And so like I know of people who put it in the basement and lock the door to the basement and put it in a safe so that there are multiple steps and multiple decision points to get there. I think, but the reality is, if we look at the data that Massachusetts has the second toughest gun laws in the country. We have the second lowest suicide rate in the country. That those things are correlated in some of the most direct ways in the data that, I respect that there's a constitutional right to it, and it's just a reality that the easier it is to get a firearm is just the easiest way to do it. And that the more access you have to it. I also think the piece is that this is why the suicide rate amongst kind of middle-aged white men continues to rise really quickly. And so having conversations with those folks, particularly focusing on the groups that are most likely to have access to guns and having really earnest and honest conversations with folks about what that is. In the town I work in, primarily Springfield, they were building a big casino, which brought a lot of construction workers into it. And they embedded kind of intentional space into paid work time for folks to access folks to talk about the struggles that they were having, and to have meaningful dialogue with each other around it. And the use of peer support in like construction fields is growing and showing a real evidence body.
Thank you so much, Errol. I'm going to move on to the next question now. So our next question is from Tom. How are the closures of hospitals and clinics affecting mental health services in the rural areas, as well as what is being done on that front?
Yeah, specific to hospital closures, unfortunately, it's very prevalent and it's still happening, not as great a pace as it has in the past few years, but the services for hospitals that are accessible by rural communities is a major concern. And currently there's also some concern about closures of pharmacies in rural communities. And oftentimes with all the closures of hospitals, the only mental health or the only healthcare professional some people in rural communities have to speak with is a pharmacist. And if that opportunity is also removed, it's obviously even worse for people getting the care and the information they need. So it's in part, that was another reason for the motivation for creating the Rural Mental Health Resilience Program, because we of course cannot create more mental health providers. We can't make the internet be more prevalent more quickly. But what we can do is recognize that people in rural communities have told us that, what can we do? how can we, make a difference? And hearing that, the information, the resources that we have, it's a start. It's certainly not everything people need, but I think the main goal of the information that's provided on the program is to give people the information to have the basic conversations and to really talk more about mental health. And the lack of services is a major concern. But I think even just as important, there are so many people out there that don't even know that they may have a mental health condition or may not feel like it's okay to talk about it. And by talking more about it, it lets people know it's okay to do that. And hopefully we can normalize the conversation about mental health across the board, but especially in rural communities, because overall there's more stigma there, and it's more difficult for people to speak up about mental health challenges.
Thank you, Chuck. Our next question is from Monica. Can you speak to the intersection of rural mental health and tribal communities? Does Rural Mind have reached there?
We are not quite 3 years old yet, so we recognize that tribal communities are one of the priority communities in terms of the mental health issues that are faced there. We had the pleasure of working with a psychiatrist from the Mayo Clinic who has done a lot of work in tribal communities and in rural communities throughout her career, and she was a guest on one of our webinars specific to someone sharing their lived experience with managing schizophrenia in rural communities. But we're working on continuing conversations with her to develop something that would be more specific to tribal communities. But there's so much to be done on so many fronts, and we're all about partnerships. And what we do is not about us; it's about how can we get people the information they need. We partner with NAMI, the National Alliance of Mental Illness, with Mental Health America, all the big nonprofits that have been around for so long. We have a lot of respect for that. And another thing that's worth mentioning quickly is that on the Rural Minds website, under the I Need Help tab, there are pages that are a comprehensive listing of all the free resources that are out there, not just Rural Minds, but through NAMI, MHA, a lot of government information, in addition to a lot of other nonprofits. But it's separated by crisis, mental health crisis resources, which of course lead with 988, but there's a lot of other information there specific to different situations that might make somebody be the source of the crisis. And then there's another webpage that's specific to mental health resources by topic, which is really easy to search. And then there's also A to Z based on the name of the organization.
Got it. Thank you, Chuck. The next question, Martha, I saw your hand raised, and thank you for putting it into the Q&A. Is from Martha. Who can I contact for more information about mental health for deaf and hard of hearing community in Florida with certified American Sign Language interpreters?
I would be glad if Devin or someone wanted to share our information. We're aware of some small communities down there. I'm aware of a church community actually that you don't actually have to be a member of the church, and they do have interpreters. They actually have folks who are bicultural interpreters, which is particularly rare. So be glad to exchange emails and connect you with some folks who might be able to be of support down there, and also some folks who might be able to help you find other communities that need to hear your story. Because I'll tell you, our community didn't always have really great interpreter services, and it wasn't until folks kind of confronted us with the reality that we were missing out on this wide group of human beings who were going to bring really important things to us that we stopped and did the work on it. So I think both connecting you with the folks who do have the resources and potentially with the folks who don't have it, so they can learn why it is so critical for them doing the work that they intend to do.
Thank you, Earl. Next question is from Harry. I believe this is for Chuck. It's mid-conversation, but it says, then you'd also need to address the concerns that they're worried that seeking help for suicidal ideation means the government will come and seize their guns. How does those laws actually work and don't work?
Yeah, there's a lot of information and misinformation across the country, and that includes rural America. So I think that, the providing more information about what truly is the situation and the facts that surround different circumstances is really important. And that, I think, goes along with the conversations about talking about mental health, because they're related. And you know, I don't have specific information to address the underlying issue of the question, but I think it does speak to the lack of valid facts that a lot of people are struggling with across the country, but also in rural America.
Thank you so much. So those are all our questions that we have for today. I'll pass it on back to Devin.
Oh, we have a few more that I'm actually interested in having all three of you answer, if you don't mind. So when it comes to your communities, when we say mental health care is working, what does that look like? How do you define what is working in your community, and what are you looking for when it's not working? What does that look like? And Aisha, I'll start with you, since you've been sort of hanging out, waiting for someone to call on you.
Now I've been taking in this valuable information from my colleagues. What it looks like in caregiving communities where people are giving and receiving care. We understand that for family caregivers in particular, there is an increase of caregiver stress, anxiety, depression, and other mental health challenges. And what it means when it's working is that family caregivers have access to mental health services and have the support that they need, and are able to engage with either peer support, mental health professionals, any, such programming that's available within their community. The challenge often is access, because family caregivers are, often called upon to be present 24/7 for whoever is in their care, and are unable then to, have access to respite care, for example, that is accessible, that is well-trained, that is because of the challenges with paid care workers not receiving, living wages, not having access to things like their own health insurance, et cetera. And it creates kind of a cascade of inaccessibility. And so, having access to all of those services within the community is a sign that things are working. And currently, a lot of folks don't. It's also financially inaccessible, as many programs that are available, many mental health programs, particularly if you're looking at mental health practitioners, do not accept health insurance. Those who do, many family caregivers are not working, and that's the primary employee-sponsored health insurance is the primary means of insurance other than Medicaid in this country. And so not having access to the means to pay for care is also a barrier to access. And so removing those barriers and through alternative means that have been mentioned here today, through peer supports and doulas and community health workers, et cetera, increases access and also increases the quality of care that individuals who are receiving care are getting as well.
How about you, Earl or Chuck? How do we know, what does it look like when it's working, and also conversely when it's not?
I can go, Chuck. So I would say the thing that's working is the thing that's always been working, is two people working together on an issue. I think the more that we can make it, so there's a sacrifice in doing human service work. You are working inherently with people who are having a hard time, and that often leads to real challenges. It shouldn't be that you are also taking, I know some group homes that are near a Walmart, that the folks who are doing this incredibly important work are taking a pay cut because they aren't stocking shelves at that Walmart. They're making less money than the folks over there. And so where we have seen agencies in some ways cut down executive pay and increase the line pay, we've seen some states take steps, Medicaid start to take some steps towards this idea that 80% of the dollar that goes to a person's services should actually go directly to the people providing that service, and not allowing kind of this poverty industrial complex to set in. Those things are meaningful. Some of the most wonderful human beings you will ever meet are the people who are doing direct care, and oftentimes they're living, I have a half brother who loves working in a group home with folks with developmental disabilities, and at one point was doing that, was working in the house and then parking his car down the street to sleep. That is a terrible turn of events. And so that is where I think the advocacy around pay equity is terribly important. And I would also say, as we talk about the intersectionality of that, those low paid workers are also the most diverse piece of the human service puzzle. That is where you will find the most folks of color, the most folks from other countries. You will find them there, and providing them a wage where they can go home and take care of their families will inherently allow them to take better care of the folks in front of them. So I think we're seeing a move towards that. But this work that we are dealing with, like a healthcare worker crisis, and that is not going to be resolved until you aren't taking a vow of poverty to do the work.
I think in rural communities, it's not unique to rural communities, but the 4 A's are really how, we should judge the if mental healthcare is working, and that's accessibility, affordability, availability, and acceptability. And I think that Aisha did a really great job with accessibility, and especially with rural communities, it's so much further to get to a fewer number of healthcare providers. And then affordability, the lack of insurance. A lot of people are on Medicaid. Greater number of people are on Medicaid in rural communities, which speaks to availability because of the fact that Medicaid only provides a much reduced rate of compensation for mental health providers versus private insurance. A lot of healthcare providers really they can't afford to practice in a rural community, which is an unfortunate reality. And then the last, acceptability, really speaks to the stigma as far as, is it okay that I have a mental illness, which is really a pathetic thing for even to be crossed, somebody's mind. It's an illness, just like, it's not the person's fault, as is not the person's fault to have cancer, diabetes, or any other disease. It's a disease, but I think the fact that you can't see mental illness, and the fact that everybody to a certain extent has days where they're depressed or they're anxious or whatever, but and so oftentimes it's just get a good night's sleep, you'll feel better in the morning, rather than having any empathy or real concern for someone who might be struggling with a real serious condition. So though we're such a long ways from having accessibility, affordability, availability, and acceptability for mental health care across the board, and especially in rural communities. But, I think we're all doing what we can to move forward and pick up what we can in terms of partnerships and resources and information to make a positive difference to improve things.
Super great. Thank you so much. And I think you each have such a different perspective just on your experiences and your communities. And I think we all have had a lot to learn from all of you. So I want to take the last few minutes here and give you a chance to sort of reflect on each other's work. I want you to do some round robin, talk to each other. If you have any questions for each other, ways you can work together. This is sort of the space for you to do that. And there's no real Q&A here, so just take it however you want here in the last few minutes, and then we'll wrap up with the final thoughts and everybody can move on with the rest of their afternoons.
I'll start. Aisha, you being here is such a radical move, that someone like you is here saying these things to folks who are, in their own world going to make power, and the way you deliver it and the kind of empathy you added to the data, I thought was so interesting and compelling. And particularly as a Black person in this world, we often were the laborers and not allowed to have the complex ideas. And so kind of in this moment, I just want to celebrate how full my heart is seeing you do this thing so well and thoughtfully, and that ability to the mental health doulas is an idea that people aren't ready for yet, but it's such an incredibly thoughtful one. And you even introducing that idea, in a few years, people will think about it like common sense. And so I've been astounded to be with you. It's been so interesting to hear about your work. And Chuck, I really appreciate, I know those communities are easy to ignore in this country. Like, you know, if you're out of the way and you're not in the big city, like what happens to you doesn't matter. And I think, you know, I might not necessarily agree on all the hows, but the fact that you're out there thinking about it for these folks and working towards it is important. And I think, you know, our field, this kind of home and community-based services, we are often forced to compete over scraps. And the reality is we've never actually been able to compete with ideas because nobody has enough resources to have their idea at 100%. And I really hope you get the opportunity to have 100% of what you need to implement your ideas, Chuck, because I think they'll change some folks' lives. Thank you guys for being here. Let me be here.
Thank you, Earl, for your kind words. I, share in your admiration and appreciation, and and for Chuck as well. What comes to mind is the kind of old disability community adage, nothing about us without us. And I really, think that the work that both of you are doing is so imperative to changing the landscape of mental wellness in this country, because not only are you advocating on behalf of people who are living with mental health challenges, mental health experiences, but you are going directly to the source for the solution. And I think that is a game changer, and you're not dictating to communities what is needed for them, but you're going to them and you're curating based on directly what you are hearing from the community. And as a member of the community, I appreciate that as well.
Well, I just want to jump in and say thank you both. I mean, as I mentioned before, we're all about partnership, and personally, I am the same way, where I always am interested in what can we do together in terms of raising awareness, raising whatever it is that we need, our goals are. But in this case, I think that awareness is really important. And as I also mentioned, we serve as like a compilation, like a portal for a lot of information that's already out there. But I think that what's been really exciting for me is to recognize both you and Earl, and the work that you are doing is really on the cutting edge. And it's exciting because some of the information that we'll be putting on the website, no doubt in the future, near future, will be because of the work that you both and others like you are doing, which is so important because it's new, it's fresh, it's revolutionary, and it's building on more of the traditional types of things, because we're not mental health professionals and we're not developing that. We're providing what's available for people to consider as far as if it's right for them or whatever. But I'm excited to include some of the works that both of you are doing and all that you're developing. So thank you for all you're doing.
I just want to say to Devin, your approach to, I think, involving us in this and your whole team. Often if somebody says, hey, you want to go meet with some researchers, my answer is no at the door. And your folks, like, you were thoughtful in your approach. It was clear that you cared about these things. And the way I got to hear about the projects you're working on was really interesting. And so I just want to appreciate you for the squeeze of this, which also was enriching, and also felt like I got to meaningfully participate in your whole team. I was really looking forward to this, and I'm really excited to see what you all do. Often when folks ask us to come into spaces, they're just asking for labor, and it felt like a partnership here, and that means a whole bunch to me. So thank you.
Right. Don't do that this afternoon. Thank you so much. I could not do any of this without you and my team and our wonderful interpreters and the service providers. And Cassandra, thank you so much for the Q&A, and my back end team for running this smoothly. But again, those of you in the audience, so to speak, thank you for your time as well. We would be talking to ourselves if you weren't out there, so thank you. With that, I'm calling on you all to consider becoming a participant in All of Us to expand health research on intersectional health needs, including mental health and disability. We cannot do this work without all of us. And just a shout out to Aisha. She didn't know she did this, but she said nothing about us without us. And all of us has adopted that phrase to say no research without us about us. So I was like, she's got the playbook and she didn't even know. So you can sign up to register for All of Us at joinallofus.org/AAHD. If you want to continue this conversation and meet with us again, we're having an open hour conversation on June 10th, which is Monday at 2:00. The link to register for that was in the chat. We will also email it out to everybody who registered tomorrow. If you'd like to keep up with us, future webinars, what we're working on next, consider joining our mailing list, and that is also in the chat as well. Again, I thank you so much for your time. I look forward to seeing you on the next one. Take care of each other. You all matter, and we cannot do anything we do without all of us. Thank you.